Jeffrey White, MD, PhD, who comes to us via LSU Medical School, University of Texas Health Sciences Center at San Antonio for residency, and Texas Children's Hospital for his Pediatric Urology Fellowship. I've known Jeff for going on 10 years now. He's a superb clinician and provider, and I am happy to have him here as one of our partners. It's up. Okay, Jeff, it's all yours.
Thank you, Dennis. I wouldn't be here without you, so I do greatly appreciate it. Let me see how to share my slides, and then we'll get started. All right, I hope you all can see this. I have been asked to speak about undescended testicles. My name is Jeffrey White. This has been a pleasure being here, and I am excited to give you this talk. There are lots of reasons that we're giving this talk. Number one, because of the survey comments from the community and staff, pediatricians, but then also it's important for us because we're starting to see some referrals for older children with undescended testicles in which our hands are somewhat tied as to how good or not good the outcomes will become. So to get started, please understand that I have no disclosures, no financial disclosures. I am on the board of the Spina Bifida Association in Kentucky. That likely won't affect this talk, and any opinions that are offered are my own. Please understand that we will be showing some pictures. So if you're with family or in public, may want to try to hide your screen some. As I said, I'm really excited to be a part of this group. This practice didn't exist in 2014. So, Dennis, Dr. Peppis, Dr. Rosenberg, Samantha Miller, and Amy Sugg have done a great job developing this program, especially since for the past 2 years, we've been in the top 40 programs in the nation out of 281 children's hospitals. So kudos to them, and I'm excited to be here. It's important to understand that not only do we deliver top tier care, but we also have tons of fun doing it. These are pictures of our staff at Halloween and then also at Christmas, and we really enjoy seeing your patients. We try to deliver that love and joy to them while they're being cared for. Please allow me to give a bit of a metaphor. I'm a big cook. Love to cook Cajun and Creole food. Ina Garten's cookbook, which is Cooking for Jeffrey, talks about her love and how she shows her love for her family and for her friends through her cooking. Similarly, as pediatricians, you all study so hard for so many years and perfect your care and try to treat for your patients, similar to your families. As surgeons and surgical subspecialists, we do the same. So try to understand as pediatric urologists, not only when you refer to us are we helping to take care of your child, but we're also trying to guarantee the next generation of Kentuckians through optimized testicular health. So what we'll be talking about today is the undescended testicle, which is abbreviated as UDT. Specifically, how does it happen? What is it? Where is it? How do we recognize it? Why is it serious? And how do we fix it? So how does it happen is due not to, as this cartoon depicts, as a forgotten testicle, but as abnormal testicular development and through abnormal descent of the testicle. So unfortunately for you, I do have a PhD in developmental biology, so I'm going to give you a nerd tour of the testicle. I'm not trying to bore you, just want you to understand why it occurs. Prior to week 7, as we are developing after conception, everyone has a bipotential gonad. During week 7, the short arm of chromosome Y, which is the SRY gene, then turns on and directs the cells of the testicle, the Sertoli cells, to produce malaria-inhibiting substance, also known as anti-Müllerian hormone, which then allows for the bipotential structures inside, such as the developing oviducts, the developing uterus, to degenerate, and also directs the Leydig cells to then secrete testosterone, which will then permit the epididymis and the internal male structures to develop and proliferate further. And so this is how these structures then develop. And then once they're developed, the testicles undergo descent. There are 2 particular phases of descent. There's a transabdominal phase, which occurs between weeks 10 to 23. This is mostly due to a combination of mechanical forces as well as hormonal stimulation. There are 2 main structures which are important for this. There's the cranial suspensory ligament, which holds the testicle in place, as well as the gubernaculum, which is another ligament that then pulls the testicle downward. So as the testicle cells, the Leydig cells, and the Sertoli cells develop, they secrete substances. Specifically, testosterone causes regression of the cranial suspensory ligament. And so that will then allow the testicle to move downward through the abdomen. And then the gubernaculum, which is a ligament that pulls the testicle down, will then be stimulated due to secretion from the Leydig cells of insulin-like factor 3, which acts on the gubernaculum, the relaxin family peptide 2, which is RXFP2, in order to activate the gubernaculum to cause contractions. The anti-Müllerian hormone, or the Müllerian inhibiting substance secreted from the Sertoli cells, also has an effect on the gubernaculum to cause contraction. And so the testicle then descends from its original developmental location, which is next to the kidney, down to the inguinal ring. Then approximately after week 24, the phase of inguinoscrotal descent occurs. This is an androgen-dependent process where testosterone is secreted from the testicle, interacts with the genitofemoral nerve, which then secretes calcitonin gene-related peptide and causes contraction of the gubernaculum further to deliver the testicle through the inguinal canal and into the dependent scrotum. It has also been shown that abdominal pressure is particularly important for this process of descent. And so, in summary, how does this happen? Through abnormal testicular development. Specifically, we will see that in disorders of sexual differentiation, the testis doesn't form properly, and so it cannot descend. It cannot descend due to the lack of proper stimulation. We often see familial preponderance of this, such as in Klinefelter syndrome. Also, there are other genetic variants or mutations which affect testis descent. All those important factors which we talked about, such as insulin-like factor 3, relaxin family peptide 2, the calcitonin gene-related peptide, as well as other syndromes such as Noonan syndrome, trisomy 18, and trisomy 21. Abnormal testis descent also occurs through other genetic issues, which we talked about, as well as anatomical or gestational errors. This is where that factor of abdominal pressure changes becomes very important, such as in prune belly syndrome or in an omphalocele, when the abdominal wall doesn't develop properly. That alters the abdominal pressure and prevents pushing of the testicle downward. Additionally, with neural tube defects, you'll also often have abnormal testicular development, and so therefore you'll have abnormal testicular descent and an undescended testicle. There's a really great summary figure here, which was developed in 2014 called the testis dysgenesis hypothesis. This was brought about due to some changes in increasing frequency and abnormal development of the testis as well as the penis. It's basically a summarization demonstrating there's increased prevalence of androgen-dependent anomalies due to all of the alterations in environmental exposures. Specifically with overpopulation of the earth, we're beginning to become more exposed to environmental factors. We're increasingly exposed to abnormal lifestyle factors such as smoking. Genetic defects and polymorphisms are increasing, as well as intrauterine growth disorders. All of these factors then affect development of the Sertoli and the fetal germ cells to then cause abnormal development of the testis, which one of the factors that it will result in is cryptorchidism. And so environmental factors include anything such as endocrine disruptors. This includes things such as diethylstilbestrol, heavy metals, and several other airborne exposures. Lifestyle such as smoking, alcohol, and obesity alters testosterone. Genetic defects, like we talked about, disorders of sexual differentiation or other syndromes, as well as maternal factors such as advanced maternal age. And so clinically, the incidence of undescended testicles is in approximately 5% of full-term males. This also has a 6-fold increase with prematurity. Spontaneous descent usually occurs around before 6 months of age, around 80% of cases, so that at 1 year, approximately 1% of full-term infants will have an undescended testicle. So again, is much higher for preterm males, around 10%. And as we spoke about, there are maternal factors such as advanced maternal age, obesity, smoking, infant factors, prematurity. For instance, 10% of premature infants will end up having a undescended testicle at 1 year of age, low birth weight, which goes along with prematurity. There's a statistic that's often thrown around that low birth weight, less than 900 grams, will have a 100% incidence of undescended testicle, and other endocrine and developmental disorders. Exposures like we talked about, such as diethylstilbestrol, heavy metals, aromatic hydrocarbons, pesticides, phthalates, all of these increase it. And so now that we kind of understand why and how does it happen, exactly what is an undescended testicle? Technical term is cryptorchidism. So crypt is hidden, orchid is testicle. The differential for any undescended testicle includes undescended testes, ectopic testes, retractile testes, ascended testes, or acquired undescended testicles. And so it's important to understand the difference. Undescended testes are testes which have never reached the scrotum. They require surgery if they're not descended by around 6 months of age. Again, we'll go into timing later. Ectopic testicles are present, but they're not in the correct place. These also require surgery. Retractile testicles are due to a combination of having prepubertal testicles, which haven't grown in size, and overactive cremasteric muscles, which will lead to pulling of the testicles up into the inguinal canal. Oftentimes, these testicles will be down when the child is relaxed, or which is usually never in the doctor's office, or during bath time. And in the office, when you're examining them, if you can get the testicle into the scrotum, exhaust the cremasteric muscles, and the testicle remains in the dependent scrotum, that is the definition of a retractile testis. These testes do not require surgery, and we follow them annually or until they're descended, because these can become ascended testicles. Ascended testes occur in approximately 2 to 4% of all boys, or 7 to 10% of retractile testicles. These are testicles which you can bring into the scrotum, but they then ascend. These require surgery. And then acquired undescended testicles are testicles which are undescended after some procedure, such as a surgery like an inguinal hernia repair or other abdominal surgery, which then they're unable to be brought to the scrotum. And so these also require surgery. And this diagnosis is guided by history to try to understand how this happened, and then physical, which is the clinical exam, to understand where it is. And so how do we classify undescended testicles? First and foremost, the majority are unilateral, only 2% are bilateral. And the classification is based on where the descent of the testicle stopped. If the testicle is palpable, which you can see on the left side of the figure in red, it is approximately 80% of all referrals for undescended testicles. They can be in the inguinal canal or above the inguinal canal in the inguinal area. They can be suprascrotal, meaning they've descended through the inguinal canal, but above the scrotum themselves, or they can be ectopic. On the right side in pink, you can see the locations for ectopic testicles. They can be cephalad to the penis, which is prepenile. They can be in the superficial inguinal pouch, which is superficial ectopic. They can be in the thigh compartment, which is called femoral ectopic testicles, or they can be lateral or posterior to the scrotum, which is termed perineal. 20% of testicles are non-palpable. This would usually be accompanied by the opposite side being hypertrophied if they're vanishing or nubbin testicle, or they could be intra-abdominal. And so how do we recognize these on exam? First and foremost, you can see from this that there's on the left side a small empty hypoplastic scrotum, whereas on the right side there seems to be a large testicle. And so it's important to always examine the opposite side first to understand what the normal testicle is, whether it feels hypertrophied and normal. Also, if the testicle is undescended, you could feel inguinal fullness, not just from the testicle being undescended inguinal canal, but also due to the possibility of a hernia or hydrocele. And it's important, like we talked about, that unilateral, it has an increased preponderance on the left versus the right. So how do we do the exams on these patients? First, if you can get them into the frog leg position, that's beneficial. It's usually difficult to do. Always examine the contralateral side and note its position, size, and consistency. For the undescended side, the examination is basically through the progression of the pictures. In A, you can see that there appears to be an empty left hemiscrotum. So you apply pressure downward at the anterior superior iliac spine and then do a medial and inferior sweep in order to try to push down any inguinal or ectopic testicle that you might be there, and then palpate the scrotum. If you can feel it, great. That means that it might be retractile or it might be undescended. If you can't feel it, you then need to lubricate your hand. So I usually just use some soap. Again, apply pressure at the anterior superior iliac spine with a medial and downward sweep, and then trace your hand that's lubricated over the inguinal area down towards the scrotum and see if you feel a pop. If you feel a pop, that is an undescended testicle. Unfortunately, they can't be brought into the scrotum. So it's really important to understand that according to the American Urological Association, the American Academy of Pediatrics, primary care physicians should palpate the quality and location of the testes at each well-child checkup so that if it is not normal and it's not palpable, they're referred early. We do not recommend any imaging for undescended testicles. The reason we published a paper on our experience here in Kentucky that imaging not only is not recommended, but it doesn't help. Diagnosis is by physical exam. And the reason it's not recommended is that lymph nodes can be mistaken for testicles. The ultrasound or the ultrasound jelly, because the child is angry or because the jelly may be cold, can affect the position of the testicle. And so we do not rely on reports from ultrasounds for positioning. Additionally, children are usually not docile during this examination. They're upset and angry, which always pulls a testicle cephalad. And so we do not trust the position that's diagnosed on the ultrasounds. So please do not get an ultrasound before referring. If we have a very hard time examining them, such as with an obese child, we may get an ultrasound to verify that the testicle is present. So why is an undescended testicle a serious issue? Is because there's decreased fertility due to impaired spermatogenesis, and there's an increased risk of malignancy. For decreased fertility, the claim is based off studies from the Children's Hospital of Philadelphia group. They performed an interesting longitudinal study where children who had to undergo orchiopexy, both the normal testicle, the normal contralateral testicle, and the undescended testicles were biopsied, and from late orchiopexies as well as normal term orchiopexies. They found that for children who were older than 2 years of age at orchiopexy and less than 9 years of age at orchiopexy have lower primary spermatocyte counts and lower total germ cell counts, which in the end equals decreased potential for future fertility. They followed these children after surgery through development, and after puberty, we're able to demonstrate that there's decreased sperm density. And this was also related to the severity of the undescended testicle. If it's unilateral, they had 83% of normal sperm density, whereas if it was bilateral, they had a 19% normal sperm density. Therefore, it's recommended to always try to obtain orchiopexy prior to 2 years of age. For this reason, when we see referrals of children who are older and who have not had the chance to get early referral, it concerns us due to their potential decreased fertility rates. These children were also followed through, and you can see the paternity rates among children who had formerly cryptorchid, that children who grew up with a unilateral undescended testicle had a near normal fertility, whereas children with bilateral undescended testes had a much lower fertility rate. And so it's important to understand this when counseling families. And we tell them this information as we do so. But not only is there decreased fertility, but there's also an increased risk of testis cancer. Lifetime risk of testis cancer in a normal male is between 0.3 and 0.7%. There's been a meta-analysis performed for the risk of boys with isolated cryptorchidism developing testicular cancer, and we can tell that there's a 4 to 7 increased fold risk of approximately 3 to 5%. Cryptorchid males account for approximately 10% of all testis cancer cases. The majority are unilateral, but it's important to understand that it is also found in 8 to 15% of cases in the contralateral testicle. So this begets some form of bilateral effects due to the unilateral testicle, which is probably due to abnormal testicle development. The risk for testis cancer is increased if it was an intra-abdominal testis, and the risk is increased if it's corrected post-pubertal. So please refer these children early. So how do we fix it so that we don't end up with a condescending testicle? The options for treatment include observation, hormonal therapies, or surgical therapies, which is the orchiopexy. The only viable options are observation prior to 6 months of age and surgery thereafter. Administration of gonadotropins may stimulate testicular descent, However, this is not a reproducible and robust effect. All of the studies that report this have confounding factors, and so it's thought to be a poor treatment. AUA guidelines specifically say hormonal therapy should not be used for testicular descent. So for observation, as we spoke earlier, spontaneous descent usually occurs by 6 months of age. Testicular descent is rare after 4 to 6 months of age. It is less than 1%. Most studies quote it as 0. So if you have a unilateral undescended testicle at 6 months of age, that child needs a referral. Please do not wait for them to age by another 6 months before referring them. And the American Urological Association and the American Academy of Pediatrics also agree with this recommendation. Surgical treatments include orchiopexy, and the technique that we use is based on the examination and the classification of the testis. The American Urological Association guidelines recommend that scrotal or inguinal orchiopexy is performed for any palpable testis. Scrotal incisions are small and they heal well in the scrotal folds and rugae, and so therefore, if safe, we prefer to proceed with scrotal procedures or inguinal procedures if not in the scrotum, or if they're palpable but in the inguinal canal. Oftentimes, these are also associated with hernias, and so we'll usually, if present, perform the hernia repair. Laparoscopic orchiopexies are performed for non-palpable testes. They have a lower success rates, which are approximately 74% for single or 63% for stage procedures, and have higher rates of atrophy up to 22%. And so when we can get away with a scrotal or an inguinal orchiopexy, we prefer that. There is a benefit to early surgery, so please refer the patients early. Early orchiopexy allows for catch-up growth, and specifically volume and function of the testicle. After 2 years of age, if an orchiopexy is performed, testis growth, catch-up growth, the volume does not ever catch up with the opposite testicle. There's a significant loss of germ cells, and so please refer these children early. The guidelines from the American Academy of Pediatrics and the American Urological Association specifically state that in the absence of spontaneous descent by 6 months of age, referral should be made and specialists should perform surgery within 1 year of referral. So in conclusion, undescended testicle is a very common problem. There's even a book on the witty names for guys with one testicle. It's reliant on many different factors. Specifically, we talked about the testis dysgenesis theory, which takes into account all factors such as environment, genetics, maternal factors, and lifestyle choices. And undescended testicles have a very high impact, such as impaired fertility, impaired paternity, and increased rates of testis cancer. So please refer these children early for treatment. Evaluation should occur at each well-child checkup by the pediatricians. And if abnormal, if you're concerned that they may be descended or may not be descended, that they may be retractile, please refer. We much prefer to have a referral that doesn't need surgery than a child that does need surgery and isn't referred until 9 years of age. Imaging should never be performed prior to referral. Treatment is usually observation until 4 months of age. And if we see that, please have a specialist referral and evaluation by 6 months of age. Surgical therapy is a treatment of choice, again, ideally before 2 years of age to maximize paternity. And treatment does not eliminate the risk of infertility or testis cancer. So post-surgical follow-up and post-treatment follow-up is important so that we can document catch-up growth and also teach self-testis examinations so that they're able to discover testis cancer before it becomes a systemic problem, if it occurs. So this is the obligatory family picture, and I'd love to take any questions that anyone may have.
So I would like to ask you, Jeff, a testis that's palpated in the pediatrician's office at 18 months of age, should there be any delay in sending them? I know you answered that question once, but I'd like you to answer it again.
No, it shouldn't. And it shouldn't get to 18 months of age. It should have been referred at 6 months of age. And I realize there are extenuating circumstances for this. Families move, pediatricians are changed, practice patterns change, but please refer them if they're not documented as down around 4 to 6 months of age.
This has been an excellent review of undescended testis. I appreciate your time, Jeff, and your expertise, and I'm thrilled as punch to have you as a partner.